Hello, ladies. I want to start today with two statistics that most people do not know. First, a woman's risk of fracturing a hip in her lifetime is equal to her combined risk of breast, uterine, and ovarian cancer. Second, within 1 year of a hip fracture, up to 30% of women will die, not from the fracture itself, but from the cascade of complications that follows: immobility, pneumonia, blood clots, loss of independence, decline. Bone health is not a soft topic. It is a life and death topic, and it is almost never given the attention it deserves in the menopause conversation. Today, we are covering bone health, metabolic health, and what a real long-term plan for menopause care should look like. Welcome to the Menopause Truth Podcast. This is part 3 of our series on how to know if your doctor is truly up to date on menopause care. We have covered hormone therapy in episode 1. We covered cardiovascular health, the lipid markers your doctor should be checking, the hot flash research, the timing hypothesis in episode 2. And today we cover the rest. Metabolic health, specifically insulin resistance, which is silently developing in far more women than anyone is testing for. Bone health and why vitamin D and calcium, while important, are often not enough. And the long-term plan, what a complete menopause care strategy should actually look like, and the questions to ask if you have never been given one. Let's start with metabolism. So, question number 1, my blood sugar and A1C are normal. Does that mean I'm metabolically healthy? If the answer is yes, your diabetes markers look fine, that's missing early disease. Here is something most physicians are not routinely testing for, and most patients don't even know. Insulin rises before glucose does. By the time your fasting glucose is creeping up, and certainly by the time your hemoglobin A1C is elevated, insulin resistance has typically been developing for years. Here's how it works. When cells become resistant to insulin, the pancreas compensates by producing more and more insulin to keep blood sugar in the normal range. During that compensatory phase, glucose looks completely normal. If you only measure glucose and hemoglobin A1C, you will miss insulin resistance entirely until it has been present for a very long time. A study published in Frontiers in Endocrinology found that nearly 30% of young adults with completely normal glucose and A1C already had high insulin levels, with indicating early metabolic dysfunction, nearly 1 in 3 people. And the menopause transition appears to accelerate this process independently of aging. Estrogen plays a meaningful role in insulin sensitivity. It helps regulate glucose metabolism, fat storage, and inflammation. As estrogen declines, visceral fat accumulates. Adiponectin levels drop, and that's a protein produced by fat cells that normally improves insulin sensitivity. And cells in the liver and the muscle become less responsive to insulin. The body compensates by pumping out more insulin. That elevated insulin drives inflammation, worsens cholesterol patterns, and promotes vascular injury long before glucose numbers look alarming. Research from the SWAN study found that higher fasting insulin levels in early perimenopause were associated with worse vasomotor symptoms, showing that metabolic health and hormonal health are deeply intertwined. What should be measured? At a minimum, a fasting insulin level alongside fasting glucose. The HOMA-IR calculation, which uses both together, gives a practical estimate of insulin resistance. Triglycerides and the triglyceride to HDL ratio are also useful markers. A woman with elevated fasting triglycerides, a low HDL, and completely normal glucose and A1C may have significant insulin resistance that is invisible to the doctor who only looks at standard markers. Question number 2, are vitamin D, calcium, and exercise enough to protect my bones? And if the answer you get is yes, that's all you need, That's incomplete for many women. Vitamin D, calcium, and resistance exercise are genuinely important. No one is dismissing them, but for many postmenopausal women, especially those who already have bone loss or who have elevated fracture risk, they are not sufficient on their own. And here is why. Estrogen is the primary regulator of the balance between bone building and bone breakdown. When estrogen falls, the cells that break down bone, they're called osteoclasts, become more active, and the balance tips towards net bone loss. The menopause transition is associated with accelerated bone loss, especially in the first 5 to 7 years after that final period. This is the window when intervention matters most. Hormone therapy's effect on fracture risk is well documented in randomized control trials. The evidence show a 20 to 37% reduction across fracture types, including hip fractures, and the benefit appears more pronounced in women under 60. The Endocrine Society's clinical practice guidelines formally support hormone therapy as a fracture prevention option for postmenopausal women under 60 who are at high fracture risk and also have vasomotor symptoms. For women who cannot or choose not to use hormone therapy, there are other evidence-based options as well. But the conversation has to start somewhere. That somewhere is a DEXA scan. It's a bone density test and a fracture risk assessment. The standard recommendation is to screen all postmenopausal women at the age of 65, but postmenopausal women under 65 with additional risk factors, including early menopause, low body weight, prior fracture, or family history of osteoporosis, should be considered for earlier screening. If no one has ever ordered a DEXA scan or discussed fracture risk with you as a postmenopausal woman, that is a gap in your care. Question number 3, can vaginal estrogen protect my bones or my heart? And if the answer you get is yes, it probably helps systemically, that is incorrect. Low dose vaginal estrogen works locally. It is absorbed minimally in the bloodstream. This is precisely why it's considered safe for so many women, even those who have a history of breast cancer or cardiovascular events. It doesn't meaningfully raise systemic estrogen levels, but that also means that it provides no meaningful systemic protection. It does its job beautifully for genitourinary symptoms like vaginal dryness, pain with sex, recurrent urinary tract infections, but it does not protect bone density. It does not address cardiovascular risk either. A woman on vaginal estrogen only who believes she is on hormones and therefore she's covered for heart and bone protection is operating on a misunderstanding that has real consequences. Question number 4, I had breast cancer. Can I never use vaginal estrogen? If the answer is a flat never, that is too absolute. Low dose vaginal estrogen has minimal systemic absorption. Multiple guidelines, including the Menopause Society, recognize that it may be appropriate for women with a history of breast cancer when genitourinary symptoms are severe and non-hormonal treatments have not provided adequate relief. The picture is more complicated for women on aromatase inhibitors, where even low local absorption may be a concern. That conversation belongs between the patient, the oncologist, and a menopause specialist together. Not resolved unilaterally with a never. Medicine rarely has clean absolutes. When your doctor answers nuanced questions with absolute answers, that is a signal worth noting. Question number 5. Are my symptoms, the palpitations, the anxiety, the mood changes just psychological? If everything gets filed under anxiety without further evaluation, that is a problem. Estrogen and progesterone have direct effects on the brain and the nervous system. The perimenopausal period, before periods stop completely, is a time of significant hormonal fluctuation. Those fluctuations, not just the eventual decline, drive many of the neurological and mood symptoms that women experience. Palpitations can be directly related to vasomotor changes and shifts in the autonomic nervous system. Sleep disruption amplifies mood changes and also cognitive fog. None of this means that these symptoms aren't real. It means they have a physiological explanation that deserves deeper evaluation, not just a referral to therapy as the first and only response. That said, perimenopausal women are genuinely at elevated risk for depression. Mental health evaluation is appropriate and it is important. The problem is when every symptom gets attributed to anxiety and nothing else gets considered. Question number 6: what is the long term plan for my health? If the answer is, we'll just see how you feel at your next appointment, that is not a plan, ladies. A complete menopause care plan should address your symptoms like hot flashes, night sweats, genital urinary changes, your sleep, your mood, your cognitive changes. What are the treatment options? What is the monitoring plan? Bone health. Has a DEXA scan been done? What is the fracture risk? What are the next steps if there is bone loss? What about cardiovascular risk? Has ApoB been measured? Has lipoprotein little a been checked? Has insulin resistance been evaluated? Has blood pressure been tracked? Has there been an explicit conversation about how menopause affects long-term heart health? Metabolic health, fasting insulin, triglyceride, body composition changes. What about lifestyle factors? Follow up. When are we meeting again? What are we measuring and what are we looking for? Menopause is not a moment to endure it and then move on from. It is the beginning of the chapter of life when the most important long-term health decisions get made or don't get made. The women who will be the healthiest at the age of 75 are often the ones who got good care at the age of 51. Here is what I want you to take away from this 3-part series. Menopause is not a symptom management problem. It is a whole body physiologic transition that touches your heart, your bones, your metabolism, your blood vessels, your insulin sensitivity, and your brain. The science on all of this has moved significantly in the last decade. Much of what was believed after 2002 has been revised, nuanced, or corrected, and yet clinical practice in most offices has not caught up. You need a doctor who thinks, who treats you as an individual, who is curious, who is current, and who understands that the decisions made in the menopause years shape the decades that follow. When you get one-line answers to complex questions, ask a follow-up. What is that based on? What are my options? How does my specific situation factor in? If you consistently leave your appointments feeling dismissed, a second opinion is not a betrayal of your doctor. It is a reasonable act of self-advocacy. Heart disease is the leading cause of death in women. Bone fractures cause enormous disability and even death. Insulin resistance develops silently years before standard tests catch it. And there is a window, a biological and clinical window in the early years of menopause where the choices made can meaningfully alter what the next 30 years look like. You deserve a doctor who knows this. You deserve care that reflects it. Menopause is not the beginning of the end of your health. It is the moment your long term health strategy should begin. And you have every right to be an active, informed part of that conversation. Thank you for listening.